Good day and welcome to another edition of Community Forum. I am Joseph Feaster, your host of this program. And today the topic that we're going to be discussing is mental illness, some of the causes, some of the treatment, some of the types of illnesses, and we're going to be talking about what we might be able to do as a community and a society in order to address and to assist in that particular issue. I have two very distinguished and knowledgeable guests joining me today. To my immediate right is Priscilla Chukwu, who is a co-founder and CFO of Ideal Healthcare Solutions, LLC. And to her right is Dr. Ebby D. Okara, who is the founder of Metis Psychological Associates, LLC. And welcome to you both.
Thank you.
Thank you for joining me today. How I like to begin is I didn't really talk about who you are and what your experiences are, because I wanted to leave it to you. I know I got the biographical information. But why don't you start, Priscilla, just by giving our audience a little bit of background on you and your company. I know you are a nurse practitioner.
Yeah.
I read that you're from Nigeria.
Yeah.
And so why don't you give a little background on that, and then Dr. Kara, would you as well do the same?
Yes, I'm a nurse practitioner. I actually came to this country maybe 1986 and continued on with my education and graduated from Massachusetts University, UMass Boston. And at that point, I went on to be certified as a nurse practitioner, adult and geriatrics. And 5 years ago, actually, my partner and I started our company called Ideal Healthcare Solutions, and which basically provides services, healthcare services at different settings. Basically, if you're home, we provide nurse practitioner house calls to the home setting. And if you're in the skilled nursing facility, we provide care there. If you're in the assisted living, we also provide care there. We happen to have this arrangement and agreement with Metis Psychological Associates, where we also provide mental health care, pharmacological evaluation, and treatment for mentally ill patients. So that's where I come in.
Okay, well, we're going to come back to that and really dwell into that a little bit more. Dr. Okara, let's tell our audience a little bit about you.
Well, I'm a licensed clinical psychologist. I've been so for the past couple of decades. And in terms of my training, I was trained at Boston City Hospital and BU School of Medicine in a program titled CMTP, the Center for Multicultural Training in Psychology. The main or the sole mission of this particular training program, is to ensure, that psychologists of all backgrounds are trained, to be sensitive to cultural differences. Differences in terms of gender, differences in terms of religion, in terms of nationality, and in terms of sexual orientation. These psychologists, including myself, are then, I guess, after the program, work in different settings, including hospital settings, which I did inpatient psychiatric work at Stoughton State Hospital. But I also became an administrator in the forensic mental health program in the prisons, for many, many years, overseeing, 5 facilities in Bridgewater. And then, of course, I also work for the Department of Mental Health, as an associate center director at Dr. Solomon Fuller Mental Health Center. This particular facility is named after the first African-American psychiatrist, in the U.S., Dr. Solomon Fuller, who is the first African-American male to graduate from BU School of Medicine as well. My background also includes being an academician in the sense that I taught for over 7 years at Cambridge College. It's a graduate school, for psychologists. in Cambridge, where I was an adjunct faculty teaching psychopathology with respect to the understanding of abnormal behavior, the etiology, as well as diagnosis and treatment of mental illness. And then, of course, private practice, which, of course, I did start about 5 years ago also in Randolph. And I'm very delighted to be here, and looking forward to sharing some of my knowledge with respect to mental illness.
Well, thank you very much to both of you. And let's get right into the topic. Again, I want to put this in context because my interest in mental illness is personal. I lost my son to mental illness 3 years ago. He was diagnosed with bipolar depression. And so I call this my ministry at this particular point in time, and I'm involved with, and I'll talk about it later, both the Massachusetts Association of Mental Health and NAMI, the National Association of Mental Illness, as well. But what in my readings and in my studies on the topic, one, just to put this in context for the audience, over 45 million people in the United States were diagnosed with some form of mental illness last year. We have a particular, the age in which diagnoses of mental illness are occurring is getting younger, so we have our youth and our adolescents. We are having the situation with veterans in terms of the post-traumatic stress syndrome and and the effect upon their families because of what types of illnesses that they come back with, particularly behind the post-traumatic stress syndrome. In your area as well, Priscilla, we have the situation where we have Alzheimer and dementia, which are forms of mental illness. Mm-hmm. So, as you said in your discussion, Dr. Kara, that there is the whole spectrum of understanding from ethnicity, race, gender, age, all of those factors are there. So having set that backdrop, can we start the program just by helping people understand what are some of the types of mental illnesses that you see diagnoses for? And then why don't we start there, and then we can talk about maybe some of the modalities, we can talk about some of the care and treatment, and we can talk about how as caregivers, what things that we can do. So why don't, if you wouldn't mind discussing that.
No problem. Well, basically, my experience is very broad. I have worked both inpatient, outpatient, and also in private practice. In that broad area of experience, including working also in the prisons as a psychologist and also an administrator, I've seen disorders, ranging from the mother of all mental illnesses, which is schizophrenia, with its subtypes of paranoid schizophrenia, disorganized type, as well as schizoaffective disorder, combining both schizophrenic type symptoms in terms of hallucination, in terms of delusions, but also in terms of mood symptoms as well too, including mania as well as depression. And then of course, the mood disorders, including bipolar 1, which is a mixed type of mood disorder, including highs and lows. It's also referred to as manic depressive illness. And of course, also major depressive disorder with or without psychotic features. Psychotic features, would include negative commentaries, about the person's body image or the person's self-esteem or self-concept, and basically, interfering with their ability, to see themselves, with any kind of strength or any kind of positive, elements. And also, the disorders also include anxiety disorders, including phobias in terms of fears of all kinds, whether it's specific phobia in terms of being afraid of flying, or being afraid of heights, or being afraid, of snakes, And of course, panic attacks, panic disorder, meaning, anticipatory anxiety, anticipating something horrible happening. And so they tend to avoid, encountering those situations. And of course, PTSD, post-traumatic stress disorder, which, could be chronic. And of course, if it's less than 6 months in terms of the symptoms, it's referred to as acute stress disorder. If it's more than 6 months, then of course it's referred to as PTSD. And of course, personality disorders as well too, including borderline personality disorder, instability of moods, seeing things as black and white, difficulty with tolerating any rejection, and the symptoms include making threats of harm to self, and then antisocial personality disorder, with respect to lack of remorse, lack of consciousness, and ability to be charming and manipulative. And of course, you tend to see those kinds in the prisons more so than any other place. So these are the types of mental illnesses that I have been exposed to and also had experience working with.
What I find interesting in Dr. Carr, by your commentary on that and identification, is some of those things just seem to be just natural everyday things that you see people presenting at different times. You talked about the person who may be manipulative. Folks may have types of anxiety, some folks in terms of phobias, and we don't diagnose it as that. But I'm going to come back to that, but I want to come to you, Priscilla, and say, okay, and I will come back to treatment as well.
Yeah.
But in what you do, you then, in your relationship with Metis, with Dr. Okara, talk to us about the types of individuals, because you said initially that you deal with adults and geriatrics primarily.
Right.
But also, what are the other, is that the patient category even in the area of mental illness that you would provide some type of treatment for? Why don't you talk about that?
Yes, we deal, because I'm certified in adult and geriatrics, so basically I see patients from age 18. Sometimes I can go down to 17, but I'm covered by law to see patients from age 18 all the way till 99, 10, whatever. So with Metis, I see primarily those type of patients. And I think sometimes what we look at mental illness, we actually think is young people who have this mental illness, or they will come into the offices. But what we've found right now with our practice is that some of these patients who have been mentally ill for a long time are now in the skilled nursing facilities, living in the skilled nursing facilities. They are in the assisted livings, and that includes the Alzheimer's patients, the demented patients, so they're all living there. And how do you provide care to these individuals who've been institutionalized for a long time, and now they're living independently in their own homes? You have to look at the whole broad picture, and that's where we come in as nurse practitioners, going into those places to be able to provide that care. Primarily with Metis, I see most of those patients with depression, with anxiety, panic attacks, and bipolar disorders, and I'm able to look at all of that and be able to treat them with the appropriate medications.
Now, in that, would you be categorized as a case manager? Would that be a case manager process, or you go more deeply into that in terms of providing the care?
I do basically the psychopharmacological evaluation and prescribe the appropriate treatment.
All right.
Medications.
So therefore you can dispense medicine in part of your treatment regimen?
Yes.
Okay. What I want to come back to, and either one of you can answer this, or both of you can speak to it as well, because what you described, Dr. Carr, is just, I mean, for many it's just going to be mind-boggling, because we, as a society, we have not treated behavioral health on the same parity as other types of illnesses. And one of the things I want to say to the viewing audience is this: mental illness is an illness not unlike diabetes, heart failure, cancer, in all forms of cancer. And our society is yet to come to grips to that. And the example I usually give is if a person fell on the floor and right here in the studio, and everyone would come and run up and talk about call 911, let's get a doctor. If one was to rip off their clothes and start running around here and running up and down the hallways, they're going to call 911, but they're going to be looking for the police department to come, not a clinician or a first responder or a medical person. So, and we've seen this nationally with some of the things that have gone on in terms of our understanding of it. But when you talk about the illnesses, doctor, that you refer to in terms of mental illness, can you talk about some of the treatment modalities that are given with regards to persons who are experiencing any of the forms of mental illness that you described?
Yes, definitely. Respect to the modalities of treatment, it could include individual psychotherapy, which I have experience doing based on my license as a licensed psychologist provider. It could also include group therapy as well too. Group therapy in the sense that the individual need some reacquiring of skill set, especially those who are schizophrenic, in the sense that they tend to lose ability for self-care in terms of ADLs, in terms of self-care, in terms of hygiene, and in terms of social interactions. So groups might be helpful, to help the individual begin to relearn, socialization skills and be able to communicate and express, their feelings, without reverting into isolation and withdrawal. And another modality of treatment, of course, will be medication management that Priscilla Nwanchukwu is an expert at. And of course, in my practice, I also do, couples therapy, individuals who have relationship problems. They're not necessarily mentally ill with respect to mood disorders, respect to schizophrenia, respect to antisocial personality disorders that of any clinical significance, just having stress in their relationships or stress on the job, and in that case refer to them as adjustment disorders, because.
But excuse me for interrupting, but there are situations where you may have a situation where one of a spouse has
mental illness, yes.
A mental illness,
yes,
and that creates distress.
Yes.
And so you're now talking about both a person afflicted with mental illness,
yes,
and another person who in effect could be a caregiver.
Yes.
And I'm sure you're faced with those situations as well.
And in that scenario, then the individual with a severe and persistent mental illness would be seen also individually.
Okay.
Okay. And then the marital therapy or the couples therapy would focus on relationship, issues, respect to communication, respect to, being able, I give them very quick scenario. Triple C's of relationship is, communication, compromise, ability to cooperate, and of course the small s, at the end is sacrifice. Okay.
I'm going to make sure that all the males be listening to this. You better repeat that again so we can so we can have that in our reservoir.
Yes.
Dr. O'Carroll. So can you repeat that once again?
Well, in my couples and marital, therapy sessions, one of the tools that I give them, are based on CBT, which is cognitive behavioral therapy approach, where you compress, major concepts, into understandable, little acronyms. So one that I came up with, is triple C's. Mm-hmm. Okay. The first C is ability, to communicate with each other. And communication is not talking at or talking over. It's talking with each other. And talking with, includes being able to give and receive feedback, and also includes, ability, to respect each other's opinion, and also ability to agree to disagree, but not disagreeable. And then the second C, is compromise. You have to give it a little. You can't have your way all the time. I talk about the 80-20 rule as well. 80-20 rule is that sometimes 80% of the time your needs will be met, and 20% of the time your needs will not be met. At those moments, don't celebrate, because it might be reversed, that your partner's needs will be 80% of the times met, and 20% of the times not met. Sometimes it's 60-40. So just be aware of that. And then the third C is cooperation. You have to be able to set goals, common goals, and be able to work together as a couple, to achieving those goals. And then the last little letter is S, is sacrifice. What have you been able to sacrifice in this relationship? What did you give up, for the common goal of the relationship? So anyway, I know I did digress a little bit,
but I think it's relevant to the whole subject of those suffering with mental illness as well. I think those would be, that acronym would be definitely appropriate there as well.
Yes, I do have many more, but I mean,
sure
that's for the show. Yes, okay, for next time.
Yeah.
But anyway, respect. Okay, go ahead.
But I want to come, and we'll come back. But I want to ask you, Priscilla. You spoke much about the treatment aspect, and also the ability in order to dispense the medications that might be appropriate for the persons who come before you for treatment. Can you talk a little bit about that, so that our viewing audience would have a sense of the types of medications? I mean, we see things advertised on television, we hear about what people do receive, and the understanding of that. I'd want to talk about that, and if you would also talk about the process of trying to regulate, because that's the other issue, trying to regulate within that. I mean, I could be off on something like lithium and all of the different medicines. Oftentimes, when a person's being treated, you have to spend the time trying to find the right balance for that particular individual. So can you talk about the types of medicines? Yeah, and then that process as well.
Yeah, we do have different types of medications, of course, that we can use there. One of the things I always say to my patients is, be careful what you see on TV and how you take it. The commercials are always there. They always will tell you that you have this long side effect of that. For patients with anxiety, you give them something for anxiety. Some of them are benzodiazepines and things like that. Anxiolytics, we call it, and there are a broad spectrum of that. And for patients with depression, you give them antidepressants. But sometimes if they do have depression with psychotic features, then you have to use antipsychotics. Now, when you look at the commercials or on TV, it tells you all this antipsychotics will cause this and cause that. And you go to the pharmacy and they give you a list of side effects. So what we find is that basically the compliance becomes an issue, because once they see these commercials and they see that, oh, it's going to cause me to, for example, grow breasts, for example, some of the antipsychotics, they'll just stop the medication without letting you know. So as a clinician, my goal when I prescribe is to say, call me with any side effect you feel you're having. Call me before you stop any medication. And I do realize there's a stigma attached to mental illness. However, I always say to my patients that, listen, if you go to a doctor and you're diagnosed with hypertension, or any clinician you're diagnosed with hypertension, you're asked to take lisinopril, for example, you continue to take the lisinopril. It does not make any difference. Here you have depression because of maybe serotonin imbalance, maybe other type of situations, or even situational depression, and you're asked to take an antidepressant and you're looking at it as being detrimental to you, and there's a stigma attached to that. So just education is is a vast part of what I do, to make sure that they understand, number one, the medication type. If it's an antidepressant, why you need to take it, how long for it to actually get up to a level, and how long it takes to get off your system. If it's ones that can be tapered off, or ones that you can stop immediately. So all of those things are part of what I do when I actually see a patient, because education is the most important thing for any mentally ill person to understand. Because once they understand the disease process and what it takes to take care of it and how the medications work, they are more compliant,
Yeah, you touched upon a very salient point, and the issue of stigma is what you've mentioned. And in fact, in a couple of few weeks, I'm going to be on a program where I'm going to be having a conversation with former Commissioner of Mental Health Sutter, where I'm going to be discussing that issue of stigma. And again, for the viewing audience, what we're saying by that is that our society, once again, has looked at mental illness differently. And as a result of that, both in our workplace, in our homes, and in our communities, if one is exhibiting or displaying some type of mental illness, it's frowned upon and looked upon negatively. Mm-hmm. And as a result of that, those who are suffering seek to hide it, their families seek to hide it, mm-hmm. their employers seek to hide it, and it's a situation where people suffer in silence. But one of the other things that goes with that is, and again, either one of you can respond to this, on the whole question of regulating the medicine, is that oftentimes those afflicted with mental illness do not want to take, particularly those who may have bipolar or manic issues particularly, they don't want to take it because they feel like super persons when they're in their manic state. Yes. And the medicines are treated to bring them down. Yes. Mm-hmm. Can you talk about that? Because that's another, must be for you, Priscilla, mm-hmm. a particular troubling issue, because they'll stop taking it and say, I'm okay, mm-hmm. and when in fact that may not be the case.
Yes, and that's the challenging part of this type of treatment, and treating patients with manic disorders and bipolar disorders, is the fact that they actually, most of them enjoy being at that manic state. I think it's a balancing act. You have to be able to give them a medication that actually will be able to bring them down some, but not put them in a stupor state. And that's the problem. Once you get them to the point where they become almost cannot feel. And most of the medications we used to use in the past, of course, is lithium, for example. Lithium, again, one of the problems that we had with lithium is the therapeutic range. Sometimes it's hard to sort of, get it to that therapeutic range. You're either too high or too low, and it gives a lot of side effects, and the side effects will include sort of not having any feeling at all. You're in a stupor state, and most patients will really hate to take that. But we do have other medications in the market right now that you can use. We can use the valproic acid, that you can look at the level, and it doesn't really cause, and there's so many other antipsychotics that we can use to actually bring you down a little bit, bring the manic down a little bit without causing you to feel almost be without feeling at all. So again, it's education. And some of them fall back and forth. They take it today, tomorrow they don't take it. Oh, I feel better today, they stop it. But there are so many other medications in the market now that is very helpful. One of the ones that we also use, Abilify, Respiratory, all of those medications, they all have their place, in the treatment plan. However, the goal here is compliance and education for them to be compliant. Tell me when you're feeling this way. Call me when you feel that way. If you feel that you feel like I'm not interested in life anymore, I just feel like every time I wake up, I just don't feel like moving, call me. So our job here is just to make sure that we're able to to titrate them to a place where they actually can function as normal people. And education really has a lot to do with that.
I can tell by your body language, Dr. Okara, you wanted to jump right in on the stigma piece, and so go right ahead.
Well, just just add to what Priscilla had said. You also mentioned, Joe, respect to the fact that individuals with bipolar illness, especially when they're in the manic phase, they enjoy it. Part of the reason is because the symptoms are different when they are manic as opposed to when they are depressed. When they are manic, they have this sense of grandiosity, this sense of full of energy. They are not able to sleep, but they're not tired. They can only sleep for 2 hours a night. You and I sleep for 2 hours a night to probably groggy all day long. For those who are manic, they are full of energy. They're more creative as well too. And then also they have, of course, poor judgment, because they're so manic, and they have this hypersexuality, issues as well too, when they're in a manic state. And they can also get a little bit psychotic as well, but it's rare, but they can also get psychotic, when they're in a manic state. Then when they're in the depressed state, it could include suicidal ideation, which is not a good thing, lack of self-esteem, self-concept, and also poor appetite. They might sleep, just too much, or sleep a little bit too little. They might overeat, they might gain weight. So they don't quite like it, when their mood is down. That's why they go off the medicine, because they want to get a little high, And like Priscilla said, that's where medication comes in, respect to making sure, that, there's the proper balance, between, the highs and lows, so that they're more compliant. I've had patients in the past who, especially in the hospital setting, they basically become non-compliant, and then of course it becomes a struggle for control as well, because they want to, feel as happy and euphoric, as they can. And in terms of stigma, I know that the issue of stigma is still part of the societal view, and it's because there's a lack of understanding of what mental illness is. Like you said, Joe, earlier, mental illness is so biological, based as well too. There are biological signs and symptoms of mental illness, and that's why medication does work, because it works on the brain in terms of controlling the neurotransmitters. These are neurochemicals like serotonin, norepinephrine, dopamine, all these are things that control, your thought process in terms of schizophrenia, whether you are having delusions, which of course are false beliefs, even in the face of contrary, evidence, in terms of hallucinations. These are of course referred to as positive symptoms of schizophrenia. And negative symptoms of schizophrenia are things, that are removed from the individual in terms of your ability to have broad affect, in terms of your ability, to care for yourself, in terms of your ability to be able to socialize. All those things are removed. These are things that you had before you had that, breakdown in terms of emotional breakdown. So when people see someone who is hallucinating, it looks strange. And of course, it's also embarrassing, okay? Especially if you're the loved one. And in terms of providing support, for loved ones, the best way, is to be there for them, but not to be overbearing. Because sometimes, caregivers, which of course are people, I refer to them in a broad sense, people, who have loved ones who have mental illness, it is painful for you to see someone that you care about, suffer without you being able to help. You feel powerless. And then in your attempt, to help, you may be even complicating things. That's why groups like NAMI, is very, very essential, because they provide a support network for those with loved ones who have mental illness, but also educational opportunity as well too, to understand what are the signs and symptoms of mental illness and what is the best approach, to assist individuals. You will not deal with the schizophrenic the same way you deal with somebody who has mood disorder, like depression. You will not deal with somebody who has mood disorder, same way as you deal with somebody, who has, borderline personality disorder. So you have to understand, what works, for each individual within your household, and what support systems, you need to advocate, for them, to receive in order for them to stabilize in the household as opposed to being, in an inpatient psychiatric facility.
I don't know, you and Priscilla both have an uncanny ability to be the segue for me to introduce the next piece I'd like to discuss, and that is a caregiver. I was a caregiver. And I say it in the past tense, even though I refer to my son in the present tense. My son jumped to his death 3 years ago, suffering from bipolar depression, and that's the reason why I said at the top of the program, this is my ministry. I'm on the board of NAMI Boston,
Yes.
Which is the National Alliance of Mental Illness. I'm also on the board of the Mass Association of Mental Health. I go out, Priscilla, and do education in our community to address the fact to say, as a caregiver, I don't feel any embarrassment to talk about an illness as I would if someone had lung cancer or anything else, or diabetes. I don't have a problem. So I'm trying to get folks to the point of recognizing that mental illness is an illness. So I'm trying to help in that conversation. And as you refer to Dr. Karanami, we're doing a lot of things, and I'll be talking more about that in a short while, because we have a walk coming up around mental illness. But I have been focusing on the caregivers, because they are really the silent partner in the situation with persons who are suffering with mental illness. And they go through a lot of what the person suffering goes through, because they're there trying to provide that support, having the limited understanding, the lack of resources that exists out there, and the inability oftentimes to be able to reach out and get the help for the person that you love because the resources aren't there. So either one of you can talk about that. I don't want to belabor, because I know you know it better. The experience of the caregiver. What is the resource? The two of you are here, but I can tell you, if one tries to go and has a person who is presenting mental illness, if you call 911, oftentimes that results in a situation where there's a tragedy somewhere in that process because of inability or the knowledge how to respond by the first responders. So I'm sure you see all of this, hear all of this, know the experiences of caregivers, both of you, both in the treatment as well as you doctor, in your therapy groups. Can you talk about that a little bit?
Yes, I mean, the caregivers are, basically part of the treatment, really. And in order for a person who is mentally ill to be able to be compliant, if they are unable to actually have a coherent sense to be compliant, the caregiver, therefore, almost carries that person. And I see that a lot with caregivers of patients with Alzheimer's, of course, and which is the other mental illness, as people are being diagnosed day by day, younger and younger. So that is a debilitating type of thing for a caregiver to be able to take care of that. You have to worry about the caregiver as much as you're worried about the person with mental illness, because ultimately the caregiver becomes actually sicker because of caring for the person with mental illness. Again, that brings back the whole subject of education, subject of reaching out and making sure that you're not just treating one person within the family, you're treating the whole family. I have patients sometimes that will come with their boyfriends, spouses, or whatever. Basically, you tend to get them into, and Dr. Kara does that too, get them into sort of the treatment plan, just so they can see that this person is not faking what they have, but this is what they have. And you need to understand what they have in order to deal with them the way you're supposed to deal with them. And also getting them involved in that plan so that they're able to help in the compliance, especially when it comes to medication in my part.
Yes, caregiver is critical. It's critical, in the stabilization of an individual, who is mentally ill. The role is very vital. That's why earlier I mentioned the importance of psychoeducation, for the caregiver. For the caregiver to be able to fully appreciate the fact that when their loved one is lying in bed and don't want to get up, it doesn't mean that they're lazy. Because sometimes what caregivers tend to do is to say, snap out of it. Just get up. I'm up, so you should be up. Well, guess what? It's not that easy. It's not that easy, because for this individual with, let's say, major depressive disorder, they lack interest in the normal things that they usually enjoy doing, whether it's watching the Patriots, whether it's watching the Red Sox. That is the last thing on their mind, because they are so absorbed, with the negative thoughts that interfere with their ability, to even see any flickering of light at the end of the tunnel. So when they are lying down, or when they're not able to cook, or when they're not able to do their own laundry, it's not because they don't want to. It's not because they're lazy. It's because it's part of the mental illness. So understanding that would, I think, be very helpful, for the caregiver, to be able to provide, appropriate support, and also to invite, the loved one who is mentally ill, to engage them and let them know, what they need. Sometimes, caregivers forget to ask the loved one who is mentally ill, what do you think would be helpful? What do you think I can do for you? We tend, to impose those who lack the understanding, our own wishes and desires onto this individual who is devastated, by schizophrenia, who is devastated, by major depressive disorder. With respect to the caregiver, when I used to work in the inpatient setting, we had a multi-family type group, where family members of those who are in the hospital, come in a group setting and talk about their frustrations, talk about their anxieties, talk about their fears, and also get a chance, to understand that they're not all alone. Right. That this journey that they're going through, even though it looks like a nightmare, that they're not in the nightmare all by themselves. Mm-hmm. And that alone is quite relieving, for the caregiver to know. And to know that they can be able to get some resources, to assist, their loved one be as stable as possible without, ending up, back in the hospital.
In a moment, I'm going to take a break, but before I go to break, I want to just raise own personal experiences, because I started a group up at my church, Morning Star Baptist Church in Mattapan, mm-hmm. Where we had conversations on mental illness. Mm-hmm. And what I found interesting first and foremost, when we started there, how in that setting, people were willing, because I would share my personal journey and experiences, and they were willing, both those who were caregivers and those who were afflicted with the disease, mm-hmm. were willing to share and to reach out and for that type of support and assistance. So that was a good start. The second thing that I found was just, as you said, Dr. O'Carroll, the responses, some of the caregivers. There was a woman that said, well, my son was in college, and obviously, because it was around the same age where my son began to present in terms of mental illness in college, stopped going to school, stopped doing homework, didn't want to get up, and her thing was, don't want to work, you're lazy. Exactly, that was exactly the terminology she used, and we worked her through the process, and that group setting did provide an opportunity for folks to feel that they weren't alone. But I'm going to go to break, but what I want to come back and focus on, my position is, while I have the two of you, the resources that exist for behavioral health and mental illness and the treatment and is just not there. Our society has not put its money where its mouth is. And so I'd want to talk about that. I know about the best team in all of these places, yes. But those of us who are caregivers, I think on the majority would say that the ability to get the resources, to get folks into inpatient, what the hospitals won't do because the payment system doesn't support as treatments in other types of diseases. So we have all of these conflicting issues, but we'll come right back and begin the conversation to talk about what resources that you can provide and what resources exist out there for those of us who are caregivers and those who are afflicted with mental illness. We'll be right back. Good. Dr. Okara's organization is Metis Psychological Associates, LLC. It's located on North Main Street in Randolph. If you're in need of his services, you can reach him at 781-963-1200. And you can check out the website at www.metispsych.com. Priscilla's organization is Ideal Healthcare Solutions, LLC. They're at 776R Washington Street in Canton. Phone number is 781-562-0468. And you can check on their website at www.idealhealthcaresolution.com. NAMI Walks, the National Alliance on Mental Illness, an organization where I serve on the NAMI Boston Board of Directors, is having a walk to raise monies so they can talk about and educate folks on mental illness and to stop the stigma. And that's going to be held on Saturday, May 10th of this year at the DCR's Department of the Department of Recreations, Otosomo Park at 1255 Soldiers Field Road in Brighton. And would like for you to, maybe you want to have a walk team. We'd love to have one from Stoughton, Randolph, and Canton for sure. And if you're interested in participating in that or learning more, please contact Karen Gromas at 617-580-8541. And I have an addendum to this as well before I get to Maxie's Delicatessen, is that there's also going to be a NAMI Mas Advocacy Day at the State House on April 8th from 11 to 3. And I would encourage people to contact NAMI at the same number that we had for Karen and find out more information on the NAMI Mass Advocacy Day at the State House, or just come up to the State House by the stairway in the Great Hall from 11 to 3. There'll be lunch to be served, there'll be speakers, and we'll also make legislative visits. But I want to come back to the ads, if I may, and talk about the Maxie's crew would like to thank Maxie's Delicatessen. They're located at 117 Sharon Street in Stoughton, and their phone number to place your orders is 781-341-1662. American Cancer Society is looking for volunteers to drive cancer patients to and from treatment. So if you have a vehicle and you are available, have some time to help some of our cancer patients make their treatments, you can reach the American Cancer Society at 1-800-ACS-6662, and you can check out their website at www.cancer.org. Ilsa Marks Food Pantry and St. Anthony's Free Market is located at the First United Methodist Church, and you can get more information by calling Christine Gallagher at 781-341-0611 or 781-341-0549. Meals on Wheels also could use your driving support in assisting them in delivering meals to our homebound individuals. And if you're willing to assist, you can ask for Jessica by calling 781-344-8882, extension 2. Stoughton Penny Savers, our paper here in Stoughton, and as they say, their business is advertising your business. They're located at 27 Rose Glen Street in Stoughton, and you can call them to place your advertisements at 781-344-4833. International Forum Show. Now, come on, folks, we need for you to tune in and find out what we're doing across the globe. Roy Cohen has been promoting this particular program, and we've had some exciting guests. We've talked to former Ambassador Yoram Ettinger in Israel. We've had some discussion around what's going on in Haiti, and we're going to be having guests from around the globe. And even we've had some folks who are Stoughton residents who are doing things internationally as well on the program. So we definitely would like your suggestions, adds to the program, and you may have some of your family who are either in the military or doing other things abroad. We'd certainly like to be able to air that on the International Forum Show. And the program airs on Sundays at 8:30 p.m., Monday at 11 p.m., Wednesdays at 9 a.m., Thursdays at 9:30 p.m., and Saturdays at 12 noon on Comcast Channel 9 and Verizon Channel 28. My favorite show, Community Forum, and the show times are in Stoughton on Thursday, Friday, Saturday, and Sunday at 6 p.m., Mondays at 8 p.m., Tuesdays at 5 p.m., and it airs on Comcast Channel 9 or Verizon Channel 28. We always welcome any of your comments and suggestions on program ideas or, quite frankly, on the programs themselves. And you can do that by sending us an email at communityforum1@yahoo.com. Community Forum also airs in the Eastern area on Mondays at 9 p.m., Tuesdays at 8 a.m., Wednesdays at 3 p.m., Saturdays at 10 a.m. on Comcast Channel 9 and Verizon Channel 22. And once again, we welcome comments and suggestions, which you can forward by email at communityforum1@yahoo.com. Well, we're back, and we only have a few moments in order to continue our conversation. But one of the things I said before the break that I wanted to discuss was the whole question of resources. As a caregiver, I find the resources not adequate for the need that exists out there. I talked about over 45 million people across this country. There's some discussion that's going on now with the Affordable Care Act in terms of addressing it. As we mentioned off air, Dr. Carr, we talked about Rosie D and its impact relative to the diagnoses and treatment of particularly our youth and adolescents. And then, of course, I've been working with former Congressman Kennedy, Patrick Kennedy, who was pushing this issue because of his own afflictions and dependency. So we're talking about the resource question. The mental hospitals, institutions are closed. You can't find enough beds in the Commonwealth. So what does one do who is a caregiver or one that's afflicted with the disease to try to get the help and resources they need to address it? And both of you should comment on that with the few moments that we have.
I think in the aspect of caregiver and being able to take care of their own person in a home setting, that's where the group, our nurse practitioner group, is a group of nurse practitioners who basically go into whatever facility you are in. You know, if it's in a home, we do house calls, and we also provide, of course, both medical and psychiatric treatment, as I said. That's where we actually come in to be able to provide that care that is needed there. And we act as a source of a resource also for connection to refer you to other, organizations that might be helpful. And of course with Metis, when you come into Metis, which is, obviously, it's an office space, we also provide those type of resources there to say, okay, these are the support groups, these are places where you need to go, these are the connections you need to have in order to be able to care for your own person at home or care for them wherever they are. The Ideal Healthcare Solutions actually started just because we realized the need for both caregivers and patients who are not able to get into the doctor's offices, patients who are not able to comply with treatment, both medically and psychiatrically, and that's why we actually started. So we have a group of nurse practitioners we're able to provide all of that and also have the connection with Metis. Thank you.
Dr. Carr?
In terms of resources, you are right, it's woefully inadequate. My experience, in the past is that it's difficult to find a bed. As the associate and center director at Dr. Solomon Fuller Mental Health Center, it was difficult, to have community resources as well, because I oversaw the outpatient mental health facilities or services, in the Mattapan, Roxbury, Dorchester, and South End, catchment areas. And even though the Department of Mental Health have contracts, with vendors, for example, Vinfen and Bay Cove, to provide them with residential services, for those who are mentally ill, to be in group homes. The beds are not enough. And in terms of case management, the caseloads are also pretty high, because I also oversaw the case management services as well too at the Fuller. Respect to adult day treatment programs, there are not enough of them either. one of the programs at the Fuller was the adult psychiatric, day hospital, where individuals come on a daily basis to receive, art therapy, receive expressive therapy, receive, group therapy, and other aspects, of care, that will make individual with schizophrenia, for example, become whole again, and also to be able to interact, with their colleagues or peers, and be able to learn some skills, that they could transfer, into their homes, if they are with their homes. And in terms of homeless shelters, for the mentally ill either, also is limited as well. But we had a facility also at Fuller, called the Albany Lodge, that provided homeless shelter on a temporary basis, for individuals, who are mentally ill. And the most difficult individuals to find resources for were those, who are sex offenders, who are also mentally ill. In the hospital setting, it was very difficult, because there was this concept, called not in my backyard. And that was, we don't want these people, living in our communities, but they have to go somewhere. They can't be warehoused, in the hospital setting. So we struggled trying to be creative, in finding resources. With respect to my practice right now, I am, of course, in individual, practice, and the resources are just various hospitals in the area, either Milton Hospital with a few beds, whether it's Brockton Hospital, with a few beds, for acute care, or South Shore Hospital as well too, and other community, centers, that can provide, services to individuals who are mentally ill. So to answer your question, it's not enough.
It's not enough. We need to do more. We're almost coming to the end of the program. We are coming to the end of the program, but I want to point out as well, when we didn't get a chance to really chat about it, and that was that our prisons are becoming another warehouse and probably have a significant population of mental illness. I want to thank you both for being here today. We couldn't cover the whole gamut of activities and things that we would want to discuss, because there's so much. This is such a large topic. But I would guarantee you, and I can guarantee our viewing audience, that we're going to bring you back here at some point in time so we can further discuss this. We can maybe isolate and take some specific areas that we can explore in more detail, because this is such an issue that's not going away. It's becoming more prevalent. We've seen circumstances around this country that have been related to mental illness. People have wrong perceptions about the illness, as well as those who are being treated. And so we'll do this again. Thank you both for being here with me today, and have a good day. Listening audience, enjoy.
Thank you very much.
Thank you very much
for having us. Thank you.